Thank you, sir, for the kind introduction. So as sir spoke in his talk also about the optics, how it plays an important role in refractive surgery, so it does in cataract surgery as well. We need to understand each of these optical elements, starting from tear film, going right up to the retina, in order to find answers and avoid these blunders that happen in IL power calculation. So let me start with few cases. So our first case is that of a 56-year-old gentleman who had come with decreased vision in the left eye. He had grade 2 nuclear sclerosis cataract. Patient was a dry eye patient. He had punctate epithelial erosions all over the cornea, which we had missed prior to doing the workup. And in his initial workup, we could see that there was astigmatism of about 4.59 diopters. If we had planned toric IOL based on these values, we would have gone with an SN689 value. But thankfully, we had picked up his dry eye and didn't go ahead with the cataract surgery. After treating the dry eye of this patient, when we repeated the biometry, we saw that the astigmatism now had significantly reduced to about 1.84. So if we had gone with the prior one, we would have ended up with a refractive surprise, as the correct model of IOL is around SN685. Sorry. So treating the dry eye or maintaining the first optical element of the eye is of utmost importance to avoid these blunders in IOL power calculation. Moving on, the earlier studies have shown that this dry eye affects the topography values. Sorry. Similar is the thing with biometry. So when there is a good tear film, the light rays which are entering the eye would be reflected back in a proper way. However, when the tear film is bad, these light rays which go inside the eye will be distorted, thereby getting us abnormal values. These abnormal values are not just important to get the keratometry for toric IOLs, but also to have a proper keratometry to get our IOL power calculations in the proper way. Moving on to the next refractive element, that is the cornea. We know that the normal cornea is okay to go ahead with the IL power calculation. But when the cornea is treated, as in for a refractive surgery, or when there are ectatic conditions present, or post-keratoplasty, or any causes which lead to irregular cornea, these are the cases where the optics are slightly altered or deviated from normal. Now, giving an example, this was a 55-year-old gentleman who had hyperopic LASIK done 2 years back. So whenever there is treatment of cornea by any ablative procedure or incisional procedure, this alters the keratometric index error, and instead of it being the normal 1.3375, it is altered as the anterior to posterior ratio of the cornea is changed. There is a change in radius of curvature, effective lens position prediction becomes difficult, and there are other factors which get affected, like the asphericity of the cornea, the tear film, whose role we saw in the prior case. It might induce irregular astigmatism also and affects the biomechanical instability. Now, when we have all these alterations, going ahead with the normal anterior corneal values for our IOL power calculation would give us erroneous results. So we need to calculate both anterior as well as posterior cornea, which is done very well using the equivalent K reading values, and it gives us simulated values to be used in our IOL formulae. The role of ASCRS online calculator and Barrett 2K calculator for these post-refractive surgery eyes has very well been proven. So for this patient, our IOL power would have come to around 15.5. This is another case, a 40-year-old lady who had come to us with cataract. She had advanced keratoconus in her eyes, for which she was using scleral contact lenses. She wanted to go ahead with cataract surgery. And wanted to be free of glasses. There are enough papers which talk about the use of toric IOLs in cases of advanced keratoconus or post-penetrating keratoplasty, but most of them have reported of having residual astigmatism after the surgery. So in these cases also, the first question comes where to take the keratometry from. As we saw in the initial scan, there was an astigmatism of around 10 diopters in the 4 maps refractive. But when we evaluate both anterior and posterior using the equivalent K reading, we see that the amount of astigmatism in the central cornea as is also seen that the main part of the cone in the pupillary area is lesser. However, the cone is more inferiorly displaced. But if we see the scan, the axis is highly varying in each zone. There is almost 10 degrees of difference in the axis of astigmatism in each zone, which says that this cornea is highly irregularly irregular. But why was that so? So probably this was because of the use of scleral lenses, and that could be a contact lens warpage. When we asked the same patient to come back to us after discontinuing his scleral lenses for 3 weeks, we saw that the cornea is much more regular now. You can see the axis variation is lesser than 3 degrees, 3 to 4 degrees in the central zone. Now, since the cone is very much in the center and her pupillary diameter is around 3 millimeter, it is imperative to use these values and not the values that you get measuring based on biometry or SIMK values. We have the updated Kane formula, which takes into account keratoconic eyes specifically for selecting toric in these cases. So a knowledge of what is the updated formula available is also imperative to avoid these optical blunders. Moving on further comes the role of the lens. This lens is useful, gives us the effective lens position. It has an influence on IL power calculation, and it also detects the optical axis. The role of lens thickness in predicting the effective lens position has been given. What exactly happens is when we have a fixed primary lens and a screen, the secondary lens and its position is important to determine the effective power of the entire system. Also, the lens is important to determine the optical and visual axis of the eye. Now, the angle alpha, which is the determinant of the centration of the bag and its role in multifocal, is highlighted in multiple studies. But the same plays an important role in monofocal lenses, especially the newer generation aspheric monofocal lenses. Even the slight decentration in these cases causes distorted vision and affects the quality of vision metrics. Moving on further, when the vitreous of the eye is replaced with silicone oil or any other changes in the media, when we do the calculation for these cases, initially it used to be that manually a conversion factor of 0.71 could be applied, but newer generation biometers have this different mode like silicone oil filled mode for calculation in such cases. Now, one such case example of a 25-year-old myope who had retinal detachment and was operated for the same. Prior to surgery, a scan was taken and she showed myopia of axial length of around 34 millimeters. But post-procedure, when she was planned for silicone oil removal along with cataract, the axial length came out to be 28. Now, if we use these two biometry values, based on the initial axial length, her power comes around minus 4.5, and the second axial length gives it up to 7. Which one is correct? This case is again related to another case which I'm coming further, which moves on to retina, that there are cases of posterior staphyloma seen in high myopes. In such cases also, like in this case, we went ahead with our biometer and implanted the IOL. But post-operative, we had refractive surprise of 6 diopters. Why was that so? In cases of high myopes where the optical biometer doesn't capture the scan, and if we go with immersion, it doesn't maintain the axis along the optical axis. Sometimes it would take the area of staphyloma into account and sometimes it would ignore. This would
LUCI, can you summarize?
Yes, I'm done.
Summarize?
Yes. So to summarize, I would say that each of the optical elements, starting from tear film, going right up to the macula, is important. A brief understanding of each structure and its role in IL power calculation, plus the knowledge of new formula and calculation is important to have happy patients. Thank you.